As you can see, we are broadcasting live from the treatment center. So I'm very excited that you guys all made the time. Thank you so much. And any questions that you guys have that come up, please feel free to put them in the chat. We've already gotten a couple via email, and we can address those as we go through the panel. I think at this point, I'm going to hand it over to Mel, Dr. Mel Pohl, and we'll get started. Thanks so much.
Good afternoon. Thanks for joining us. Me and Dr. Fong should be here any minute, because otherwise when I say something and I wait for a response, there will be nothing. So I hope that what we talk about today is provoke some questions and comments. That's the whole purpose of this dialogue. I wanted to just start off talking a little bit about pain recovery. The term came about 18 years ago when I started doing treatment for people who had co-occurring substance use disorders and chronic pain. And some of you know I did that in Las Vegas for many years. I've been here at the Pointe Malibu for about 5 or 6 months. And we're creating a program with a curriculum that really meets the needs of people who have this co-occurring set of disorders. The differentiation that I make in pain recovery, people use the term pain management, and I kind of bristle a little at it, and I usually correct people. No, we don't have a pain management program. And the reason for pain recovery is that pain management, if you think about it, is basically medications or procedures, whether it's injections or ablations or ultimately surgeries. And that's not what we do here. We help people manage their pain in a recovery atmosphere. And as you know, recovery involves letting go of an attachment to a substance will fix the problem that I have. And it turns out that opioids often aren't a good solution for people with chronic pain. The more they use, the more they need to use because, of course, of tolerance. Eventually, they become physically dependent. And some of you may be familiar with the term opiate-induced hyperalgesia, which we'll talk about a little later when Dr. Fong and I get going. So the real point of pain recovery is it's letting go of opioids and incidentally other mood-altering drugs. We often have patients in the facility who are referred to us who are drinking alcoholically or in heavy moderation, let's say, and using sedatives, benzos, or sleeping medications that are habituating in combination with sometimes stimulants, whether it's prescribed medications like Adderall or Vyvanse or Concerta for a diagnosis of ADHD. Again, one that people are very attached to in their recovery process. And now one of the significant drugs that we're treating is THC. And we're actually going to talk about that tomorrow with my colleague, Ben Court. So I look forward to that conversation, especially if he shows up. Anyway, we have the ability to detoxify people from the habituating drugs that they're using and have become dependent on. And as you know, if you work in the field of addiction, that's a process. Separating the patient from the drug is a significant, challenging process. And that withdrawal time can be short or often prolonged. And again, when my colleague gets here, we'll probably talk a little bit about detoxification and alternatives to detoxification, which would be medications for opiate use disorder, like buprenorphine and methadone, which are both considerations in the long-term treatment of somebody with chronic pain and substance use disorder. So the recovery process starts with separating from the drug, but really what's involved, again, as many as you know, I know there's a bunch of recovery professionals on the Zoom today, but recovery is really a process of finding a way to navigate through life on life's terms, if you will. Using the fundamental treatment approach with cognitive behavioral therapy and dialectical behavioral therapy. And we have some expertise in acceptance commitment therapy, really finding out what works in life, what's valuable in life, and then making commitments over the course of time to such activities. And then a variety of different approaches to the orientation towards the pain. So the real task at hand, the real goal of treatment here at the Pointe Malibu is in helping people let go of the diagnosis, the physical identified diagnosis that I have and then you could fill in the blank, slip disc or broken arm that never healed or complex regional pain syndrome. The labels that get put on these conditions people get attached to that label. And as a result of that attachment, they suffer more. So we help people detach from the actual physical definition or diagnosis that they come in with and allow them to really move towards an acceptance of the concept of learned neural pathway, the fact that the pain is not in the tissue. The tissue is not the issue. The pain really is in the brain. It's the hardest thing that we do here. It's the hardest job for somebody with chronic pain to really manage. What are you talking about? I had a patient who had chronic headaches for 30 years, was quite debilitated, spent most of her days in bed. And when I explained learned neural pathways and central sensitization and the fact that the pain really is in the brain and not in the physical aspect of the body, she looked at me and said, "Are you telling me my pain is in my head?" And I said, "Of course your pain is in your head. You have chronic headaches. Like where else is your pain?" But the challenge is really helping people see this is real pain, and there is factors that influence the real pain, emotions and thoughts that need to be dealt with. Did you I was hoping that Dr. Fong was here, but no such luck. Yeah, well, I kind of want him to hear the question, and he's almost here, right? So let's give Dr. Fong a big round of applause when he gets here, but also let's give him a moment to approach the chair of honor. But just to sort of wrap up the concepts, we really approach chronic pain as a condition that involves mind, body, and spirit. And much like addiction recovery, it has to be dealt with in that comprehensive fashion. So I'd like to welcome now my colleague, Dr. Tim Fong, who is just entering the frame. Nice to see you, Dr. Fong.
Pohl.
Pleasure. Long time.
Pleasure.
We're on camera, just so you know.
Yeah.
They've been waiting anxiously for you.
The internet is a power.
It does. It's great to see you. It's really good to see you.
What a great drive it was.
It's beautiful, right?
It's beautiful.
Yeah.
So relaxed.
Oh, good.
Like that's part of the
good.
therapy.
Well,
just the drive here.
I've been having a dialogue with myself for the last few minutes, waiting for you to get here.
For 30 years.
I'm not relaxed. That's my style. Yeah. The assessment of how narcissistic a person is how long they talk on the phone after the phone has been disconnected, right?
Right.
So really, welcome to the Point. It's great to have you here.
Thank you for having me. I know we talked as getting to the point, or we also had a title of Get to the Point, but I'm here at the point. So it's amazing to be here. Thank you, Dr. Pohl.
Yeah. So should we take a question to get us going, Michelle? Michelle.
I'm here. I'm ready. Hey,
Let's
Dr.
hear.
Fong. Better late
How
than
are
never.
you, Michelle?
I'm good.
She's off camera.
Okay, so we had a question come in via email. It's a good question. Why do so many opiate addicts who manage to get clean subsequently experience debilitating body pain in the absence of opiates? Also, what can they do to address that pain in the absence of opiates?
Can you repeat that because she's so far away?
You didn't hear that?
It's a little echoey because it's such a spacious spot we're in. But let's go ahead and repeat that for the audience there.
Me?
Yeah.
Oh, geez. So basically, people come off opiates and they have pain. What can we do for folks like that? And I think the question implied people have more pain as they come off opioids in their recovery process. I don't know if you've seen that or what do you think about it?
Oh, you have as well. I mean, by way of background, I've been doing addiction psychiatry since the 90s. And I've learned a lot about pain, even though as psychiatrists, we don't get training like you do, of course, for pain management. But here's a few things I've learned. So clearly when people are on opioids for a long time, the body and the brain and the mind adjust. And you've seen this as well, this whole state of what we call hyperalgesia, where you're much more sensitive to pain when you're on opioids. The surprising thing that I've seen over the years is when you take patients off opioids, the pain gets better. The first thing I've said to patients all the time, by getting you off opioids, your pain will get better. They always say, no, this isn't going to happen. I don't know what you're talking about. This won't be true.
And do you, I mean, what's your experience as to why they're so resistant to the idea that they'll get better when they come off opioids?
I think it's fear. Pain hurts. Pain is a miserable experience. And there's that fear of the unknown, the uncertain. If I'm in pain, what do I do?
Yeah, for me, when I sit with a patient and give them this same explanation, hey, life's going to get better, you're going to have less pain off the opioids and on them. And as I see their face contort in fear, they typically say that's not true because I tried being off opioids. And after 6 hours, the pain ratcheted up. So I know I need them.
Yeah. So, but whether that's withdrawal or whether that's just being what we call psychiatric or psychologically new, where you don't have these opioids that diminish me. Very challenging. I'll give you an example. We have a patient in the hospital right now, and she's 80. She's been on opioids for about 20 years. Scoliosis, lumbago, low back pain, variety of other medical conditions. And we asked her pain doc, what's the reason you still have her on 4 to 5 Norcos per day? And he's like, well, chronic pain, she's always been on that. But it's clear to us that those Norcos are impairing her judgment, making her pain worse, impairing her sleep. She's not opioid use disorder or addicted, but she's on it.
That is the challenge, right? An 80-year-old sitting in a group with a bunch of heroin addicts doesn't really identify as an addict.
That's right.
Right.
That's right.
How do you guys handle that?
So our first task is to determine, is it appropriate, medically appropriate for her to be on long-term opioid use? That's our first thing. The second thing is, we said to her today, your pain doctor feels that you should be on this for pain management. We feel that the opioids are actually making your mental health worse. Your depression is worse, your sleep is worse. We think there are better ways to handle your pain. And that's the fundamental question here. What are those, quote, better ways? And of course, it starts with being off opioids. And number 2, being on the right medications that are not going to make your pain worse. We have a whole toolbox that you use, that I use to help manage pain, whether it's antidepressants or it's patches or it's stress management. And all these things do work, but I think the key is to recognize that opiates do not cure pain, and in fact, just being on it makes your pain worse.
And just to underscore what you've said, and just to make a few other points, there's no study that suggests that long-term opiates helps people with chronic pain. Maybe 20% improvement, and it's only a mild improvement. So, but when a patient has 6 out of 10 pain and they get to 4 out of 10 pain for even, it ends up being, maybe an hour or 2 at the most, or they go to sleep, that's relief. And they end up pathologically pursuing that. Not terribly different than somebody who's using a drug with addiction. The other thing is that over the course of time, the function decreases in people on these chronic opioids. So you and I know that taking her off pain management, I talked before you got here about the difference between pain management and pain recovery, with management being medication and procedure, and recovery really being about embracing life on life's terms. And people don't function as well on the opioid as they do off the opioid. And that ought to be the criteria, not what's your pain level.
When I went to medical school, I was taught pain is a fifth vital sign.
Yeah.
And again, this was all at the start before the opioid crisis. So I'm that generation where it was very clear, if you don't treat aggressively with opioids, you are doing a disservice to malpractice.
Yeah.
Led to the unfortunate opioid crisis where we're at. We're now teaching our medical students in the 21st century that pain is part of life. Pain management is more about functional, about recovery, and the expectation that you'll have zero pain is really a false expectation.
Yeah.
And I think that's really done a huge disservice. So I think we're looking at another 20 years of self-correction about, what's a proper pain management. 0 out of 10 is not feasible when you have multiple medical problems, when you aren't doing the thing to prevent pain. So our 80-year-old lady, she's essentially inside her home, does not exercise, very limited physical movement, no social connections, which is the antidote to pain, right?
Yeah.
No focus on her nutritional state, and no focus on her sleep hygiene. All the things behaviorally that actually make pain go down.
Yeah. And it's probably, she's got what we would call a shrunken life. She doesn't have joy.
That's right.
And joy promotes engagement with others and
reduces pain.
So it all reduces pain. Or there's another factor. It might not even reduce the pain, but the pain just doesn't factor in as much. That sometimes patients after a mindfulness course will say, I still feel it, but it just doesn't feel quite the same. I don't have the same connection with the negativity. And that's one of the things that we're working on really hard here is the mental association of pain is bad and pain is the enemy, and I have to avoid it at all costs. And that's the first noble truth, says suffering is really about aversion, right?
Very good.
Yeah.
What else you got, Michelle?
I do have one more question. What are some non-medicinal ways for people to better manage, in parentheses, better manage their body pain? Yoga, flotation, tanks, walking, etc.
You're a pain guy. Let's hear your toolbox, and I'll show you. I'll share a few.
I'll show you mine if you show me yours.
Right, that's right. That's right.
So first of all, my pain treatment skills really came mostly from patients. I mean, I'm a family doc and an addiction certified family practice fellow, but the pain experience was, we just saw so many people who were on opioids coming into addiction treatment, and about half of them at the end of treatment would say, well, what are you going to do about my pain, doc? And I'd say, I have no idea.
Yeah.
So I got interested. That's a kind of puny answer to send them back to the prescriber, because that's really their only choice. So, I got interested in what alternatives are effective. And my God, the literature for resources for people with chronic pain is staggering, non-opioid treatment. So, beginning with the thought process, I mean, all the varieties of cognitive behavioral therapy, changing the message that my pain is killing me, that sort of potent, what we would call a cognitive distortion. So CBT, we have CBT trained therapists here, and there is, if you look at the studies, there is efficacy. It's interesting. CBT works better in people who are motivated and believe it's going to work.
Right.
So, a sense of optimism and positivity and moving towards something rather than moving away is one of the key treatment methodologies that we use. I don't want to take them all.
No, the way we teach medical students and residents is that, pain, like depression or anxiety, it's a biopsychosocial sign and symptom. Therefore, you have to have biopsychosocial treatments.
Can I add spiritual to that?
And exactly. And that's the thing. For years as MDs, we focus on the bio. What medications can we give? What treatments can we do? We don't focus enough on the psychosocial treatments of pain management. You touched on them, CBT, counseling, therapy, mindfulness-based practices, acupuncture, which I fold under bio treatments.
Yeah.
But the social treatments for pain management, we almost never talk about that.
Yeah.
Support groups, social connections, social activities, rebranding, and thinking about that. I think about one of the patients I've worked with through the years who always described for me, he's like, before I came to you, I was not able to play tennis at all. My back hurt, my elbow hurt. I was relying on these opioids. I just didn't have that exposure. When we treated his depression, he got interested in playing again.
Mhm.
But the key point was really, I don't want to play without pain. I want to play like I used to 20 years ago.
Yeah.
It was reworking that expectation.
Sure.
You can play with pain and still enjoy that activity.
Yeah. Yeah.
That I think is really an interesting area for
it-
reworking that.
It really is. I mean, we treat athletes, of course, and when the opiates go away and the
Yeah.
other substances leave the picture, they're often energized in a way they haven't been in a long time,
Right.
and they want to go at it. You know,
Yeah.
they want to lift heavy in the
Yeah,
gym,
there
and
we
they
go.
want to. So pacing is really key, because
Right.
we certainly don't want somebody to injure themselves or overdo their exercise.
Right.
But exercise is where it starts. I mean, for your 80-year-old,
Yeah.
you know, motion is lotion. My
That's
friend
right.
Sherry Corbett says that.
You know, I learned a lot about this stuff just going through life. So I'm a very avid golfer, avid tennis player. And a couple months ago, I came back from a golf trip, and 2 days later, my back locked up, tremendous pain. And it was very, very painful.
You're going to complain about it a while, are you?
Right. Yeah. I couldn't walk. I couldn't stand. I literally could not make 2 steps. And I'm like, I better call Mel. I need some drugs here. But it taught me a lot about what it was like to be in acute pain.
Yeah.
But it wasn't chronic. And I knew that the acute pain would go if I did those treatments, biopsychosocial. I had the proper medication, I had a proper massage, a proper stretching, and I reworked my mindset, my psychological mindset, saying this pain will fade. It's not permanent. That's different than chronic pain, but it really taught me about how scary pain can be.
Yeah.
The idea that
Yeah,
I mean, I have to be this way.
Yeah, that's
my
well
rest of
said.
my life.
And then you look at somebody who has a painful condition and there's no end in sight.
That's right.
And there actually was a very interesting study. They put patients' hands in a tub of ice water, very painful.
Cold pressure test.
Yes.
That's right.
And the patient was, one group of patients was told, you have to keep your hand in there for a minute. And the average length of time people were able to do that was like 48 seconds. They told another group, you just keep your hand in there. We'll let you know when to pull it out. And their average length of time was 22 seconds.
22 seconds. Right.
So they couldn't tolerate the uncertainty of what was coming.
Right.
So, you know, one of the things we try and do here at the Point, and what we're really aiming to do with pain recovery, is to help people identify the power of their brain in influencing the amount of pain. Before you got here, I was talking about the phenomenon of LNP, or learned neural pathways, which is a synonym for central sensitization. Basically, the volume knob inside the brain center of pain is turned up, and we can help people. You know, we can't do much about the degenerative disc disease.
Right.
We certainly, you know, fusing a spine that's degenerating is a terrible solution.
That's right.
Doesn't help hardly at all. And then they have a fused spine and the post-surgical complications and an attitude from a surgeon that says, you know, I did what I should have. It's your problem. So they're in that state of, you know, being disbelieved.
Sure.
But all that aside, you know, we have somebody with an emotional and a cognitive process that really engages their pain and makes it worse. You know, that fear response,
Right.
as I talk to patients, you know, what happens when you're afraid? You know, your muscles get tight.
Tense up, adrenaline starts coming in,
you know,
trauma gets re-triggered.
Yes. And that's a whole other topic that we might get to, but yeah.
Okay.
So what you do with your mind and how it affects your body. And then there's a converse experience, which is what's happening in your body and what does that do to your mind?
Right.
So in other words, I feel a tension in my stomach, and what comes up is anxiety and fear, like I'm not going to know what to say next, you know, whatever the narrative is in my, and it's busy, you know, my mind is busy as I don't know about you, but you know, it's.
Yeah. I mean, that's really advanced stuff. I mean, I don't hear about a lot of programs really digging as deep into pain as mine. And, you know, you have this beautiful ocean here. Do people go into the ocean?
Not only
an ocean pressure test.
Not only do they go in the ocean, they go surfing.
You go surfing. So surf therapy, it's a thing.
It's a thing. We have Christiana is our program manager, just newly appointed. As I grabbed her. She's been on staff for a number of years, and she's a very talented therapist. And she's a surfer, and you know, she took clients out. We had a 78-year-old woman who learned to surf and who had chronic pain. And it was just as we described. It was just the pain almost melted away because she was out there, you know, in the waves, facing her fears. she threatens to get me out on a board. I'm not so sure about it.
Maybe that's the next episode. But you know, the thing about pain and chronic pain, we think about sometimes it does get reduced through these other treatments. And sometimes I've had a lot of patients say, I never thought I would have my pain be reduced. And I've often wondered, well, what is it that we did? Some of it was just listening. Some of it was getting them off the stuff that was making it worse. Some of it was inspiring them to do that physical movement. I can't say it enough. Physical movement and even just walking or even just stretching is enough to release those good neurochemicals that are associated with pain relief. And that's why Tai Chi is a big one. And massage therapy and a lot of the Eastern practices, the acupuncture. But again, Tai Chi is something we're doing more and more at UCLA, highlighting that this is something we need to be doing. And even if you have profound medical conditions, you can still practice Tai Chi because it's about balancing movement and meditation at the same time.
And yoga, you know, sort of a cousin of
that's right.
Tai Chi, and Qigong is another one that I had an instructor in the program that I worked in. It's really wonderful. I think we do Qigong here as well. But yeah, it's movement associated with the mind and connecting, because we're disconnected, right? We're disconnected. And really, you know, you mentioned modern medicine. You know, what do we do? Well, we treat the body. What about, you know, I give talks to physicians, and, you know, I sort of get these looks when I talk about the emotions and the cognitive processes. And, you know, I hope that my psychiatric colleagues, the students that you get to train, you know, exposed to your insight, are coming to a different stage. But really, it's either the mind or the body.
Right.
And, you know, you guys treat the mind, but what do? You mainly use Prozac, you know, and
that's right.
The body, you know, what can we physically do for somebody with chronic pain?
Well, it speaks to, I think, a little insider for the audience in terms of the training that physicians get for managing pain. And it's very thin. You know, you don't get a lot in medical school. And when you go through a psychiatry residency, it is not mandated that you have a month or 2 months in pain. Even for our pain management specialties, so anesthesia with a year of pain management, there's very little psychiatric training there. So that crossover hasn't really happened. It's starting to. Like, when did you do a pain medicine fellowship per se?
No, that's what I was saying. My training has really been self-study and treating patients and learning from
clinical experience,
from the best
there's no
teachers,
substitute.
You know.
But I think a lot of patients, at least, they get frustrated when they come and they say, hey, why aren't there more combination programs, and why aren't I getting more answers? I think that's part of it, where we're not training as well as we can, that holistic pain treatment approaches.
I think there's a resistance in sort of Western medicine to really embracing those kinds of techniques. You know, they give them lip service. I mean, even now, you know, I get all these CME emails, you know, and sort of bullets about information, and you read about non-opioids. So the words are there. And the words, I think, started coming around because the opioid epidemic really, as you sort of alluded to, you know, sort of gave this upswing of people taking prescription opioids, and then heroin in about 2013, and now it's the synthetics, you know, the fentanyl that's being imported in illicit substances. And, you know, people are dying in higher numbers than ever.
And that's the sad part, you know, and that's the part, but we say, what's the best treatment for pain? Of course, it's going to be prevention. And you think about who are the folks that are most at risk: depression, physical trauma, psychological trauma, active and past substance use disorder, all those things. But I've been thinking about this a lot. You know, the kind of patients we see in mental health with profound chronic pain, of course, the medical ones, but the fibromyalgia, you know, those are the kind of clients that are particularly very hard because their pain is real, but the imaging doesn't show it. So I think that's an area really where I think prevention of pain is so critical. So even when you get someone, to start really talking to them about how do you prevent pain so that the next 5 years of your recovery, it doesn't reemerge. By the time they show up here, I imagine, just like at the hospital, it's pretty well severe. They've been through this for years and years.
The cool part is we get to take people off drugs, as you do, and we do get, often we get that bounce. You know, if somebody comes in dependent on an opioid, after a couple of weeks off the opioid, having gone through detox, they have an improvement in their mood and affect because the opioid effect is gone, but also often their pain is not gone,
Right.
but maybe it's 5 or 10% down, and
Yeah.
then we start working on increments, rather than oxycodone, which takes it from an 8 to a 6.
Yeah.
Doesn't last, but
Right.
gets that effect. But we're looking for half a point here and a point here,
Yeah.
with a meditation, and people are into prayer, so they
Yeah.
have a spiritual connection, and you get a point of relief there, and you take an ibuprofen, and you get
Right.
a point of relief, and you're down 3.5, 4 points, which is
It adds up.
40%.
It adds up.
It's
adds
better
up.
than any opioid works.
Well, and I think that's what you're highlighting here. And this is the first time I've been here on property.
Oh, I didn't know
I
that.
think one of the strategies there is, where can pain recovery really happen from? Like when you're in a hospital, whether it's a psychiatric hospital, a medical hospital, it's really sterile. It's a lot of lab coats and needles and things like that. It's not a place to recover. And we're under so much pressure by insurance to have people discharged within 7 days or 10 days. If you're in a residential setting like this, your pace can change. And when you have a healing environment, I think that really does matter. And it's huge. Like I never had a chance to visit your place out in Nevada all these years, but I imagine it was similar, that it
Wasn't like this.
It was. There was no ocean view.
There's no ocean
view.
in Nevada, first off.
But it was a dry heat.
Yeah, they had a mild summer. It didn't go over 120.
That's right.
But in all seriousness, you say it well. I mean, people who are lucky enough to get to a place like this really are blessed. I have a patient in San Diego, which is where my home is made, and he was a 78-year-old guy who has back disease, degenerative disc disease in the back. And he was referred to me by a physical therapy program because he wasn't making progress. And he's on about 8 5-milligram oxycodones a day. So pretty hefty dose of oxycodone. And he's been on it for years. He's snappier. The medicine doesn't, just like the lady, he's in bed more than he's not. The best thing he can do is sleep. And, he's a robust, energetic guy. And we've had a couple of conversations, and he's finally said, okay, I don't really believe you that I'm going to be better, but I can't continue to live the way I am. That's that bottom that people hit. And he's off to a detox, and we'll see how he does. He's has Medicare as a resource.
Right.
He's not going to a facility that really embraces pain.
Yeah.
And his big concern, and my concern for him, is, well, what if I have pain when the opiates go away? What am I going to do with it now?
That's I think, again, going to take about 15 years, 20 years to kind of change that mantra. Once we get some education out there for doctors to say your pain will get better when you're off opioids. I think it goes back to, that's 40 years of marketing and culture saying opioids will relieve your pain. And if you don't give opioids, you are doing a disservice to the patient. And we have to reverse that. So, but we know more. Yeah. We know more now in 2021 than we did in the mid-90s.
Do you think it's reversing? I mean,
definitely. Like, think about our first year medical students who come in, they are hungry for knowledge on how do I treat pain? How do I stop the opioid crisis? I mean, that's really, really profound. And I look at the technology we have for pain and opioid use disorders. I mean, buprenorphine has really revolutionized what we do. It's not the end all be all, nor should it be, but the patients who've said to me, wow, I can function. My pain is way better because I don't have to take these other more potent narcotics. That's really, really profound.
How do you use buprenorphine with pain? Do you use the device?
Yeah, so again, off label, it's not really used. It can be used for pain management. I use buprenorphine for opioid use disorder. I've been doing this since 2002. We have a wide variety, whether it's coming off of pills or heroin or fentanyl. People respond to it. We treat the withdrawal. We use it for maintenance. It does have an anti-anxiety effect. It does have a moderate analgesic effect. So we just end up using it a lot for outpatient basis. We don't use it as much as we'd like in the inpatient setting or in the residential setting, but it's FDA proven and it works. I think a lot of patients, yours and mine as well, they say, I don't want to be addicted from one opiate to another. And I say very clearly, what I'm giving you is a medication. It's not it's correcting the normal parts of your body. I'm not giving you something to become physically dependent on. So my experience with buprenorphine has been phenomenally positive, but I'm also going to be select. I'm not always going to always give it to every single person. There are a lot of patients who come in and we say, this is just not a proper medication for you. We don't think it's going to work. But when used properly, really, really great results.
Yes. I bristle at the the verbiage about Suboxone or buprenorphine that medication is treatment.
That's right.
Because I don't think medication is treatment. I think medication is a beneficial adjunctive part of a
Biopsychosocial treatment,
biopsychosocial
right,
and add spiritual at the end, you know.
Right.
And you know, when I say spiritual, it's important for the folks that we see here to at least understand that the world isn't me, you know, this shrunken place that I've lived for the last decade or two or three really is bigger. And, you know, it's hard not to see some kind of spirit when you look out the window.
That's right. That's
you know,
right.
and that's a beginning. You know, something bigger than me enables me to get well. And often I think that, you know, it's one of the principles of the 12 steps, but it's also in a global sense, something that we can offer to patients. And that, you know, I'm not a spiritualist, but I think, you know, part of meditation and Qigong and yoga can be brought to a place where there's some connection with some, whatever you call it, force in the universe. You know, it doesn't have to be God for sure.
You know, there's so much mythology in the work that we do here, and there's a lot of people who have very firm set ways, and there are others who have tried different things. And I think that's part of the real strategy is that, you know, for some folks, when they get buprenorphine, they say, this makes me feel normal, and now I can do the work of recovery.
Yeah,
that's a profound state. There are others who just say, I just want to continue to be numbed out. I don't want to face realities. And that's an example of a client who should not be getting buprenorphine, you know. But at the same time, I think, you know, I'm optimistic where we are as a field. There's so much more work that needs to be done. And there needs to be a lot more places like here that are sensitive and in tune and aware that you can't just do a cookie cutter treatment plan. You just can't shove people into residential and say, thou shall do these 10 things and expect good results.
Sure. And is your approach typically to prescribe buprenorphine and keep the patient on, or what's your longitudinal look at it?
Oh, yeah. I mean, I always say to patients, we're going to continue prescribing this medication as long as it continues to give you benefit. And as soon as it begins to no longer give you benefit or have side effects that are not healthy, we're going to taper you off. I've had some patients on it since 2002, nearly 19 years of experience. I've had others that had very short detox experiences, 2 or 4 weeks, and that's what they needed. But and I think that's where it gets struggling. We don't want the same algorithm for every treatment. It's got to be unique.
But how do you know who to do what for? I mean, we really
that's the real story. That's the
clinical finesse,
right? And so for my outpatients, it tends to be, well, I want to see you fully functioning for a full year, relapse, stable, all markers of recovery. So sobriety, home, health, purpose, community, abstinence, fully functional connection. And if you're going a full year and your recovery is rock solid, that's when we can start talking about tapering. And then it's interesting, some folks, as we start tapering, they get the urges come back, or their sleep isn't as stable as it once was, or their physical pain. And they're like, I don't want to go down because I'm concerned I'm going to go back and go back and get opiates.
And that's an indication to leave where it is, I guess, right?
Absolutely. And others would taper down, no problem. They jump off. And then here's a key one is that even if you're off buprenorphine, you're still my patient. I still want you to come back and see me. You know, you don't have to be on medications to see a psychiatrist. So oftentimes people were surprised at that they can still make an appointment.
So you talk to them, do you?
I actually talk to them. Yeah,
that's great. I love psychiatrists who talk to their patients.
Rare, but no. Actually, that's a core thing we do.
Good. And your training is as well.
Oh, absolutely. Yeah.
You know, I'd love to teach a session for your residents.
Sorry, what's that?
I said I'd love to teach a session for your residents if that.
Oh, well, we'll get you in. I know we teach our med students, our general psychiatry residents, our addiction psychiatry fellows, all folks who need.
How many fellowship spots?
Right now we have 4 addiction psychiatry fellows, and surprisingly in America, there's only about 1,500 board certified addiction psychiatrists. And that's out of like 2 million doctors. So it's really not that many.
No, at all.
And of course, addiction psychiatrists are different from addiction medicine. Oh, yeah. You are addiction medicine.
Family medicine.
I'm addiction psychiatry, but we're, you know, brothers from another mother, right? If you say. Right. But that's the whole point. I think a lot, again, patients and families oftentimes think that they're getting someone who has profound experience, and sometimes that's not always true.
No, I know.
We really have to get people in the right proper specialist.
Well, there's not enough, right? So that's one of our the needs of the medical system, let's say.
That's right. That's right.
I'm wondering if Michelle has a question for us. Michelle, you have a question at all?
You didn't come on camera, Michelle?
I'm on camera now.
Oh, she's
You're
on camera
not. I stole
now.
it from you.
Okay.
What are your thoughts on the difference between emotional and physical pain? And I have a second question. At what point, if a client comes to you or patient and they are either abusing opiates from prescription or or prescribed opiates, their body is physically dependent on it, do you identify them as an addict? And how do you address that with them?
Which one do you want to do first?
Well, this is a core question. There's a difference between addiction and opioid use disorder versus physical dependence. If I have diabetes and I'm on insulin, I'm physically dependent on my insulin to survive. I think we had, in fact, had another case like this last week where she met only tolerance and withdrawal as the symptoms. None of that behavioral symptoms of opioid use disorder. No using more than intended, doing things that are against her moral code. It was just tolerance and withdrawal. Is that addiction? And again, by the letter of the law, it's almost, but it really was physical dependence. So what I look for when my initial evaluation, am I seeing only signs of physical dependence, which would be tolerance withdrawal, or am I seeing physical signs plus the behavioral signs of addiction? And if it's behavioral signs of addiction, of course, we're going to use our addiction treatment tools. But it's not easy to differentiate. And a lot of times I'll say things like, tell me about your relationship with opioids.
That's a great question.
And instead of saying, do you think you're addicted? Or, how's your pain? Tell me about, how do you feel when you take these medications? How do you feel when you go to the pharmacy and pick them up? What do you think's happening when you're asking your doctor for more or less? And that'll give you more of a probe. You gotta get a sense. Is it because their pain is not well treated? Is it because the opiates undertreating or overtreating it? Or simply, are they using opioids for treatment of depression, anxiety, and other emotional pain? Opioids, of course, they release suffering, physical and emotional. We forget that, but it's our patient who can then inform us, and then it's up to us to differentiate which lane we're in. And that's kind of how I
that's a great framework. I wouldn't say opioids reduce suffering until they don't. Because of course it's not a good long-term solution. But they do the mental and the physical effects, compared to an ibuprofen, which is really good for pain but not for pain, the big umbrella. And maybe we get to that next. But when in seeing patients, just as you've described, who really don't meet, they're not addicts, they don't have the kind of addiction that the addict has, where they're seeking the drug and behaving and misbehaving in a way. Misbehaving is judgmental, but they're breaking the rules. But I tell you, this gentleman I mentioned, who's 78 years old, he described timing his meals because he wanted to take the pill on an empty stomach because he knew it would work better. So that's preoccupation.
That's right.
That's one of the criteria. He drove and he didn't really feel safe driving, but he had to get to the pharmacy to get his medication. Danger. So, that's a second. He clearly had dysfunction in his relationship with his wife. That's the third. So we've got mild substance use disorder without tolerance and physical dependence. It still doesn't convince me that it's the same. I think that DSM definition is kind of cruddy. And of course they exclude tolerance and physical dependence if you're getting a prescription.
That's right.
So that it doesn't even
it's so messy. And I think even more so, I boiled it down to even very simply, do these opioid pills you're taking, do they improve the quality of your life overall, give you more freedom? Or do they create problems and side effects? And
why are you still taking them if the answer is yes?
And that invariably tends to be a lot of, and we get a lot of vice versa. So couple areas that I'm concerned about is on the flip side, overreaction. So we do get a lot of some patients who I've seen who do require ongoing pain. I'm particularly thinking about some of my cancer patients I've worked with. And then they get restrictions at the pharmacy, or they get limitations because of insurances. And now they're left with more anxiety, more distress, and they feel like they've been treated like opioid use disorder patients. So this is a new lane of concern I have with folks who should be getting opioids, but now don't, and they actually get more emotional pain. The second lane I'm really worried about, again, are doctors who are then overreacting, the same thing, and are too short for prescribing. well, I'll give you an example. We had one in the hospital about a month ago who had major back surgery, but because her history in the chart said opioid use disorder, they said, "Oh my gosh, don't give her any opiates. She's an addict. Don't give her anything." But she had major surgery, so they literally gave her like 3 days of work, and they said, "Well, after 3 days, she should not be taking anything." So, but it created all this anxiety and doubt and more emotional pain.
Yeah.
It didn't really need to be because she got labeled as opioid disorder.
I mean, addiction, as you know, is a terribly stigmatized disease, and people suffer as a result of that stigma. So it's really unfortunate. I wanted to go back though, to people that have that condition that we've been talking about, which is sort of, it's not really addiction, but it's not just the
Like
same
misuse,
as, well,
or
complex
problematic-
complex dependence.
Complex dependence.
So it's something more than just physical dependence.
Right.
Jane Ballantyne is a pain doc from
Mhm.
Seattle who coined that term. We used to use it a lot because there's some relationship that is not quite the same as your relationship to your blood pressure medicine.
Right,
It's just different. And it's because the opioid, as you know, works in the reward center. So there is some effect that people are getting, sometimes conscious, sometimes subconscious, that really impacts their desire to use and continue to use, despite negative consequences, like their life is worse as a result of it. And the rock and the hard place question is, but what am I supposed to do without them? And then we have the discussion, well, you might actually get better if you separated from these drugs.
Right.
And then you could do 18 million things to deal with the psychosocial, spiritual aspect of your chronic pain. Because my take on that is that the non-bio, so psychosocial, spiritual, the mind part of the pain is 80% of the overall experience of chronic
80%.
80%. So that's the work.
Yeah.
You can get 80% attended to if you work on your anxiety and your fear and your anger and your depression. And we have ways to do that, whether it's cognitive behavioral therapies and DBT and ACT, acceptance commitment therapy, or mindfulness practices, or neurofeedback. We have an expert here in neurofeedback. I didn't get a chance, and we have a few minutes left to talk about trauma and your experience with trauma. My clinical experience is 9 out of 10 patients who come to the point with chronic pain have some sort of serious trauma in their
I'd say it's like 11 out of 10, and it
Yeah.
goes back to what trauma really is: physical, biological, psychological, social, and it rewires how the brain perceives the world and how it interacts. So, and it just creates so much. And I think even more than that, it makes you, it changes how you sleep. It changes how you eat. It changes how your body. When you think about someone with trauma, I think about this. They're on fight or flight mode for years. Sure. They have cortisol being generated at levels that was never really intended. Yeah. And then when you have declines in self-care, you're really a raw nerve. Of course, you're going to be much more susceptible to pain and both physical and emotional. And I think disentangling that is very tough. And I think that's where it goes back to, again, so many clients and therapists and providers of medical care, we don't make that common basic link that you have a history of trauma, both past and now that's been reactivated by something. That's why your physical and mental pain is much worse. But what can we do to reactivate it? I think now in 2021, when we've all lived a global trauma of COVID for 18 months, we're all experiencing this. And we all have to figure out, how do we keep the stress, physical and emotional stress of trauma maintained, so that it doesn't then generate more long-lasting emotional and physical pain. Yes.
And you've alluded to both of these, but one is we're here at the point where students of the polyvagal theory. I don't know if you know
polyvagal theory. No, I'm not familiar with that.
My God, I'm going to teach Dr. Fong something. How about that? Steve Porges is a psychologist who coined the term over a decade ago, but it's really about the 3 functions of the vagus nerve. One is to freeze, fight, flight, or freeze. So freeze is the dorsal vagal nerve. Then there's the sympathetic nervous system that you were describing, which gets everything heightened. And then there's the ventral vagal system. And there's actually a branch of the vagus nerve that goes up to the face and into the brain, of course, but it innervates the eyes and the ears and the throat and the mouth. So phonation and vision connection, it's just what you talked about.
Yeah.
And he defines the healing power of co-regulation.
Okay.
This.
Yeah.
Which we missed during COVID so much.
The connection.
Yeah. Even wearing a mask deprives you of about half of the experience of co-regulation. So, and one of the things that we're doing here is he has a safe and sound protocol, and it's just the coolest thing.
That's a cool name.
The whole thing is so cool. I can't even tell you. I mean, I'm learning stuff in the last year that's it just knocks my socks off. But basically, it's an auditory program that's embedded in music, and he picked 70s music, but it's the tonal variants of a mother's lullaby that they've embedded in this sound program that you hear, and it actually turns down that ventral vagal, or it enhances the ventral vagal system, turns down the sympathetic overdrive. And it's, we have an earphone set up and an app, and patients are just, what happens is they get sort of tenderized, they're more accessible.
Right.
And it's not a real, you listen and something changes, but I've been listening. So I'm just cool as a cucumber.
Is it really only 70s music, or do you?
They have classical variety as well. Those are the only two. So I'm going to talk to them about that. Okay. It gets a little tedious.
Well, because music therapy, of course, is a big thing that we use. I myself have listened to a lot of just 80s music, and it was just calming me down.
Yeah.
And part of it is a reminder of your childhood, but there is something soothing about stimulating that auditory nerve.
Yeah, and it's really not the music; it's what's embedded in the music. You don't really hear or notice, but I'll give you the link. It's quite interesting.
That's very interesting. I've not heard of that.
And patients do it, and their pain level improves, and their anxiety diminishes just enough so that we can access what's underneath, which is the emotions. And, I mean, we have to help patients deal with their, call it a connection with the pain. People get, pain serves a function.
Right.
They don't like to acknowledge that, but, we call it secondary gain in psychological terms.
Which is interesting. I'm trying to think, culturally, where do we get this theory or this belief that we really should not have any pain? And I remember growing up as a kid in the 80s, it was like no pain, no gain, but that was really more about bodybuilding and being tough and strong and being fit. But something feels to me like it happened that, where it was like, really, let's not even have any pain at all.
Or anxiety,
or anxiety or depression.
And we have a pill for everything. So who did that? Pharmaceutical industry. I mean, I think it was a very serious endeavor by the marketing campaigns of people out to make profits on drugs, on people's behaviors. I think really that's a big part of it.
That's really the early 90s.
Well, but Prozac was when? It was 60.
Right? Prozac was 87.
Oh, 87?
Yeah.
So, Purdue, the first drug that they created was Valium.
Yeah.
And they sold more Valium tablets than anything else in the United States, any product.
Yeah.
So, I mean, I think has been a marketing sale that you got something wrong with you got a diagnosis, and we can fix it with a pill.
We can emotionally sanitize.
Yeah. And the Buddhists, on the other hand, have a different approach altogether. They say suffering is inevitable.
Right.
And there's a way out, but it isn't with taking a pill.
Yeah.
So, we have a few minutes left. Any burning desires? Michelle, you got anything over there?
I sure do.
Oh, sweet.
I got one more question. What is the best approach to getting people off opiates? Immediate cessation with replacement meds, or a long wean off the opiates themselves?
Good question.
That's a great question. The question again is, what is the best way to, quote, get off opiates? Rip it off real quick or go slow? My experience has been a little bit of both, but for when I use buprenorphine, there is no tapering off the other opiates. We just stop the opiate, whether it's heroin or prescription pill, and we'll transition into buprenorphine. On the inpatient unit, we'll tend to do a little more of a taper if we have a little more time. But really, it's using both. I remember reading some studies about how to get off buprenorphine. Is it better to get off, or is it better to taper off? And it ended up being about both were about as successful. Yeah. So I think it truly is individualized. It depends on what's dangerous. You're not going to continue to taper someone off heroin by telling them to use heroin in America. So at least my approach has been both. But For the outpatient world, I just like going off that opioid that they're developing addiction to and switching them onto buprenorphine medication. If I'm doing a classic detox, it's on the outpatient side, it's still going to be quicker rather than slower. But
yeah, a variety of approaches. I would agree. Certainly, if somebody's resident, we stop whatever opioid they're on, and then we use buprenorphine in a pretty rapid taper, usually within a week or two, because our goal is opiate free, including buprenorphine free. We don't always achieve that. About maybe 15-20% of the time, people have protracted pain or withdrawal symptoms, and we'll use a low dose of buprenorphine. The dose for pain, as I'm sure you know, is lower, probably 8 milligrams a day versus the 16 to 24 milligrams for the opiate maintenance dose. But I also would comment that for outpatient treatment, I mean, I've had patients who are on, let's say it's 68 milligrams of hydrocodone a day. And in the medical parlance, you go by one of every couple of weeks. So you go down.
Yeah.
So that could take anywhere from 4 to 12 to 16 weeks. The problem with slow taper is every time you drop the dose, the pain goes up because of withdrawal. So it's a tough road. If people can do it, it's safe, it's recommended, but it's really tough to do. It's the same as benzos. I mean,
benzos are a whole other story, but there is that. And I think part of the message really is that you have to stay involved with a treatment team and provider that you have faith and respect and a good relationship with. A lot of times I see a lot of patients come to me and they're like, oh, my doctor's terminated with me, said this is your last dose of opiates, and they're left for the bag. Or I talk to the doctor and they're stringing them along, for no purposes, because they don't want to, quote, lose them as a patient.
Which is,
it's all over the place. And I think we do have very interesting FDA-approved medications for opioid withdrawal, not just buprenorphine, but also methadone, and now some other new ones like lofexidine. And we have naltrexone for opioid use disorder, but not opioid withdrawal. What I will say is I don't like to see patients come in and do a lot of the things that are sold to them as this is the way to get off opiates. So we're talking about the ultra rapid detoxes. Then they're still out there,
still doing them.
Or these others come in, I'll give you an injection of this miracle and you'll be cured. We still see this from time to time, but unfortunately, because sometimes people just don't know any better, or they're so desperate for answers. They're like,
well, and they want a fix, right? I mean, they want, detox and out.
Right.
And you and I know detox is not worth anything without treatment.
That's right. Yeah. And that, isn't it amazing that even in 2021, that ultra rapid detox is still a thing.
Yeah.
But I remember 15 years ago, they had those big billboards out there
in LA,
radio ads.
In LA.
And this was all cash pay. And unfortunately, we saw the results of that. It was ongoing, unfortunately, addiction and relapse.
Yeah. So addiction, chronic pain, chronic illnesses that interact, but really require more than just a quick fix. You got to be in it for the long term. But I'm glad you're around and participating.
As you are as well. And one last thing, I think a lot of times patients say, well, where am I supposed to go? Where do I get actual help? Where do I actually get a proper detox? I mean, again, our hospital at UCLA, we have both the medical and the psychiatric. We can do it all. There are a lot of other, quote, detox facilities in and around Los Angeles. Residential programs do detox.
Yeah, we do.
Here there as well. So there are places. It's just navigating that treatment, which takes some time.
And I'll just mention one thing we're going to be using here. It's called Remedy, Remedy. It's an app for chronic pain, and we're going to have a version of it here that'll be basis of our curriculum for people with pain. But if you have chronic pain, or if you have a patient with chronic pain who can't access an inpatient residential treatment, check it out. Remedy, Remedy. It's cool stuff. It's great.
Thank you, Dr. Pohl.
I think it's a
great.
Yeah. Thank you, Dr. Fong. It's really good to see you.
Let's come back.
Yeah.
Thanks, guys. If any of you have any further questions, please feel free to email me. We will be here tomorrow at 1 p.m. for another panel. If you're interested, ping me. And again, thank you so much for your time, and I hope to see you soon. Bye-bye.